one and all. We welcome you to another episode of the Wednesday Special Thyroid Clinics organized by the Indian Thyroid Society. So Indian Thyroid Society is organizing the thyroid clinics under the leadership of the foremost eminent conveners, Dr. Sarita Bajaj Madam, who is the president of ITS, Dr. Pramila Kalra Madam, who is the scientific chair of ITS, Dr. Mini G. Pillai Ma'am, who is the treasurer, and Dr. Arun Menon sir, who is the secretary of ITS. So for today's session, we have Dr. Alok Sachan sir as the chairperson, and we have a case discussion on thyroid-associated ophthalmopathy, moderated by Dr. Sanjay Suran sir and Dr. Roshmi Gupta ma'am, and followed by the quiz by Dr. Rajiv Singla sir, and then we have the monologue that is approach to thyroiditis by our very own Dr. Pramila Kalra madam. So following the last session, Dr. Rajiv Singla sir will discuss the answer keys, and finally the winners will be announced. So without further ado, we will start off the session with the introduction of our most eminent chairperson, Dr. Alok Sachan sir. So, sir is presently the professor of the Department of Endocrinology in Sri Venkateshwara Institute of Medical Sciences, Tirupati. Sir has about 35 publications of both national and international level. Sir has the sir's areas of interest are diabetes and bone. Sir has received A.V. Gandhi Award for the Excellence in Endocrinology. So, sir, I would like to request you to say a few words and then introduce Dr. Roshmi Gupta ma'am for the case discussion.
Good evening all, and thank you the organizing team of the Indian Thyroid Society, chairperson Dr. Sarita Madam, Dr. Pramila, Dr. Arun, Dr. Mini, everybody. Thank you all for having me here. Now we are going to start this session on a very interesting case of thyroid-associated ophthalmopathy. And for the moderators, we have today Dr. Sanjay, who is Associate Professor in Department of Endocrinology from SMS Medical College, Jaipur. Dr. Sanjay is also Secretary of the Endocrine Society of India, and he is the Organizing Secretary of ASICON 2022. He has more than 40 publications in various national and international journals, and he has published 3 chapters in international books. His areas of interest are diabetes mellitus, nutrition, metabolism, growth and development, type 1 diabetes, disorders of puberty, thyroid diseases, and reproductive endocrinology. He has multiple awards, and one very big international award is from Government of China for excellence in the field of medicine. He has also received an award from Epicon 98 for Jaipur. Welcome, Dr. Sanjay. And our second moderator is Dr. Roshmi. So, Madam is consultant ophthalmologist, Manipal Hospital and Trustwell Hospital, Bangalore. Madam's area is problem solving in oculoplastic on orbital diseases and mentoring trainees and fellows. Her area of interest are thyroid eye disease, pediatric oculoplasty, and orbital surgery. She has received multiple awards, including received the Best Video, Best Orbit Paper, Raman Mittal Best Paper Award at OPAI, and Sujata Savitri Rao Best Oculoplasty Paper Award at AIOS. I welcome both the moderators. And with this, with permission of the chair, can we go to the case now? For case presentation, we have Dr. Y. Rajesh Reddy. He is a senior resident in Department of Endocrinology. So Dr. Rajesh will take us through a very interesting case today. Over to you, Dr. Rajesh.
Yes. Good evening, everyone. Today I present a case of 57-year-old gentleman who is a case of Graves' disease who was diagnosed in January 2020 on carbimazole since 2.5 milligrams once a day. He presented with the complaints of swelling in the both eyes since 4 weeks. He was apparently normal 4 weeks ago until he noticed swelling in the both eyes, insidious in onset, slowly progressive. It was associated with grittiness in the both eyes. Along with, there is a history of redness in the both eyes and history of excess tearing from the both eyes. He has also noticed a pain in the eyes, and there is no associated history of decreased vision, and there is no history of fever. At the diagnosis point, he was having history of palpitations and sweating, which were decreased currently, and his appetite is normal. There is no history of weight loss, no tremors, no history of difficulty in standing from sitting position, no polyuria, no history of increased frequency of stools, no history of irritability and restlessness. Past history, he had history of swellings with palpitations and increased appetite, weight loss in January, and he was evaluated and was diagnosed to have Graves' disease and was initiated on carbimazole 20 milligrams once a day and propranolol for the symptoms. He has been in regular follow-up and his dose was titrated according to the T4 levels. He is also a known case of diabetes mellitus since 20 years on tablet metformin with glimepiride and vildagliptin and a mild non-proliferative retinopathy. There were no other comorbid conditions. Personal history: he has normal sleep, appetite being normal, bowel and bladder habits are regular, no ethanol consumption, no history of smoking. No similar complaints in other members of the family. Medication history: he is on carbimazole 2.5 milligrams once a day, metformin 500 milligrams twice daily, and glimepiride 2 milligrams twice daily, and vildagliptin 50 milligrams twice daily. At this point of time, the differential diagnosis would be thyroid-associated orbitopathy or orbital cellulitis, orbital myositis, or keratoconus fistula.
Thank you, Dr. Rajesh. Can I request some moderators to take over, please? Dr. Sanjay and Dr. Roshmi.
Thank you, Dr. Alok. I would like to express my gratitude to Indian Thyroid Society for having me here today. It's such a pleasure to meet all of you. Dr. Alok, Dr. Sarita, Dr. Pramila, Dr. Mini. Dr. Rajesh, this sounds like building up to a very interesting case, but if you would just tell us all exactly how many months since the onset of Graves' disease, because you said January 2020, and now you said since 4 weeks he has the eye problem. So exactly which month is this?
This was actually in the July of July of 2020, ma'am. Actually,
so roughly about
6 months after the onset
6 months after the onset.
Yes, ma'am.
And he has a lot of eye symptoms,
Yes,
and
ma'am.
it is bilateral.
Yes, ma'am.
Right?
Yes.
And but he feels his vision is fine.
Yes, ma'am.
Okay. So when we go look at this differential diagnosis, let's remember that, I mean, from the ophthalmic point of view, common things are more common. And so whether it is unilateral or it is bilateral, the commonest cause of proptosis is thyroid eye disease. And that holds true. Okay, so you very correctly put that as your first differential diagnosis. Now, I would worry about either orbital cellulitis or keratoconus fistula coming into the differential diagnosis because it's unlikely that it's going to be bilateral. These are more likely to be unilateral.
Yes.
Orbital myositis, again, it can be bilateral, but it's pretty rare that simultaneously both eyes present at the same stage. It can be sequential more commonly if it's orbital myositis. But go on, tell us a little more about this patient.
Since he's already a known case of Graves' disease, the most common will be thyroid-associated orbitopathy, ma'am. Points against the favor of this other differential diagnosis are there is no history of fever in case of cellulitis, and the presence of bilateral eye signs in the eye symptoms in this patient. In case of myositis, there can be initially single muscle involvement, later followed by if it can progress to other muscles also, ma'am. In case of keratoconus fistula, patient can if it is a unilateral disease generally, unless there is a bilateral fistula, patient is less likely to have proptosis bilaterally in this case. So mostly in case of this Graves, could be thyroid-associated orbitopathy.
Yeah, okay, Rajesh. Actually, patient was started initially on the carbimazole 3 times daily or when he was diagnosed with Graves' ophthalmopathy, at that time he was on 20 milligram OD.
Yes, sir.
Am I correct?
Yes, sir.
Okay, and propranolol also at that time.
Yes, sir.
Okay. So, according to your symptoms and signs, we are left with the diagnosis of this thyroid orbitopathy, because in cellulitis we'll have the other symptoms also, and like other inflammatory signs also. But have you described the visual acuity of the patient?
Sir?
Visual
He
acuity.
has mentioned that the vision was normal. That's what he's mentioned.
According to the patient, he feels that he does not have any decreased vision or any other complaints, sir.
Okay, so it was not examined.
Yes, sir. In the according to history, it was there were no complaints of decreased vision, sir.
Okay, it's fine. Okay, then continue.
Hi, Dr. Sanjay. Nice to meet you.
Hi.
Dr. Rajesh, you might go on and tell us about the examination. We've got the history. Now, anything more about the examination you want to tell us?
Yes, ma'am. Patient was conscious, coherent, and oriented to time, place, and person. There were no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. BP was 130/70 millimeters of mercury. Pulse was 86 per minute with regular normal volume and no radial and radiofemoral delay. Temperature was 98.6 degrees Fahrenheit. Respiratory rate was 16 per minute. There was no dermopathy or acrophagy. Thyroid was normally palpable, soft in consistency, non-tender, was moving with deglutition. And on examination of eyes, he had a proptosis, and he had a spontaneous eye pain along with a gaze developed pain, and he had eyelid edema and conjunctival redness was present. There was no eyelid redness and chemosis, conjunctival chemosis or caruncle edema. And his clinical activity score was 4/7.
Okay. At this point, it would have been very important to actually document what the vision level was like. And in fact, if you look at the particular criteria for dysthyroid optic neuropathy, it's not only the vision. We need to be talking about the pupil, the color vision, and the fields. So as you're presenting, the other signs and symptoms, it would have been good to have those on board to let us know that, yes, is all this there or not? That is one thing. And the other thing in the presentation, in the clinical features, it's very important to talk about the eyelids, because what's known is 90% of thyroid eye disease patients have eyelid signs. They all have it. That's part of the diagnostic criteria. And clinically, it becomes very important, because if there is significant lagophthalmos, difficulty closing the eye, it can lead to a corneal breakdown. And there we go into the definition of sight-threatening disease. So this is a very nice description of the clinical activity score. Along with that, the vision and the eyelid signs would have been important to prognosticate. But please go on, please.
In systemic examination, in cardiovascular,
Wait. Actually, you are just jumping to systemic examination now. Still, eye examination is not complete now. So we were discussing regarding this this CS score. No? So now actually we are including that maximum CS score also. No? Yes. So you should include that one also.
Yes, sir.
And other thing, in examination part also, we should have the examination visual acuity, color vision, as madam was already described. No? So that was also not done.
Yes.
So other thing is that grading of this eye disease orbitopathy is not done.
Right, Dr. Sanjay, maybe he's got it next on, because it's not only, and what Dr. Sanjay is trying to make the point, Dr. Rajesh, is that not only is the clinical activity score essential for deciding the plan of management, also the grade of the eye disease. Like, is it mild, is it moderate to severe, or is it sight-threatening? That also becomes a very important deciding point.
Yes.
So because in examination we should include all the things, because it is a Graves disease, Graves ophthalmopathy. We are describing the case of ophthalmopathy only. So local examination should be in big way, comprehensive way. So whenever we are just asking the patient to go for ophthalmology examination, we used to write the comprehensive ophthalmological examination. So it should be described in that way. Can you go previous slide? Okay. Okay, next. Okay, next slide. So there's in ophthalmological examination, it's very incomplete now, no grading. Even the proptosis, you've not examined the exophthalmos with the trypanometer. We should describe this is also the part of examination.
Yeah, Dr. Sanjay and Dr. Rashmi. Partly the incomplete record is because patient was following for eye problem with another eye hospital, and that was not in Tirupati. So those records were not available to us. So we are presenting whatever information we have. Their treatment prescription we have, but a lot of examination related data from the other eye hospital is missing. So that was a big place where he had gone to a different city to get that part. So that's why some part of the examination may feel incomplete. I'm sorry, you can go ahead with it.
Yeah, Rajesh, yes.
Systemic examination, cardiovascular S1 and S2 were had and there were no murmurs. And respiratory, there were no bilateral normal vesicular bloodstones were had. And nervous system, there were no focal neurological deficits. And abdominal examination was soft and there was non-tidal and bowel sounds were well had. Summary is a 57-year-old gentleman diagnosed with Graves' disease on anti-thyroid medication on a regular follow-up, presented with features suggestive of orbitopathy with a clinical activity score of 4/7, an impression being Graves' disease with moderate to severe active orbitopathy.
Okay.
So this moderate to severe, this term that you're bringing in, Dr. Rajesh,
Yes,
this is, the grading from the ophthalmologist, is it?
Yes, ma'am.
Yeah. So the moment we see moderate to severe, we are presuming that the palpable fissure height has increased to more than
More
2
than 2 mm,
millimeters,
with
and
exophthalmos of
proptosis
3 mm.
exactly. Proptosis has increased to 3 to 5 mm, and so that's where we are at. The lovely thing about using the same language as in quote unquote, the same terminology, is the moment they talk moderate to severe, we can actually in our minds visualize what the patient must be like. Go on, please. What are you planning?
At this point of time, since the disease is very active disease, we plan on starting on immunosuppressive in the form of his investigations are he requires steroid therapy, ma'am, pulse dose of steroid therapy.
Yeah. So go on, tell us what you've been doing.
He requires initially a 500 milligrams of methylprednisolone per week for up to 6 weeks, followed by 250 milligrams per week for another 6 weeks. Dose should not be exceeding more than 8 grams cumulative dose, and to look for again clinical activity score how the disease is progressing.
So what was actually done in this patient? Go ahead.
Is the investigates at the time of diagnosis in the January was 2020 was T4 of 169 nanogram per ml, and TSH was 0.009, and T3 was 1.3 nanogram per ml. And during the course of treatment, his T4 has dropped to 79 nanogram per ml at the time of presentation with the orbitopathy.
So we have the investigation report of T4 only. Why not T3?
He was presented. He had only these records, sir, actually.
Okay.
Then scintigraphy done at the time of diagnosis, as we can see here, homogeneous uptake of homogeneous uptake in the both lobes of thyroid gland. Provisional diagnosis being Graves' disease with moderate to severe active orbitopathy and type 2 diabetes mellitus with mild non-proliferative diabetic retinopathy. Patient was continued on anti-thyroid medications, and he was also given IV methylprednisolone 500 milligrams per week for 6 weeks, followed by 250 milligrams per week for 6 weeks. During the follow-up, initially clinical activity score has decreased to 1/7 with improvement in symptoms. Later, after few months, patient again presented with worsening of vision, with redness in eyes and pain associated with pain and restricted movements in eyes, and clinical activity score as assessed by ophthalmologist was 7/7.
If I might point out, Dr. Rajesh, that usually at the initial visit, you'd be talking about 7 points.
Yes,
And by the time we are talking about the follow-up visit, but probably this scoring has come to you from the ophthalmologist, it goes into 10 points,
yes.
Isn't it?
Yes, ma'am. There is a decrease in Snellen chart by 1 line, and ocular motility decreasing by 8 degrees.
Right.
And so we got a record of 7/7.
Show us the MRI, show us the CT.
Here we can see about increase in the bulkiness of the inferior rectus, medial rectus, and superior rectus. Here lateral rectus is also we can see.
Okay, go on.
In
Next,
the MRI,
Hmm.
in the MRI, we can see here grossly increased inferior rectus with the medial and superior rectus, and the insertion of the tendons being thin and the other part of the muscle belly being increased. Here also we can see the post-contrast enhancement with the increase in the bulkiness of the inferior, medial, superior, and lateral rectus muscles.
Okay, I'd like to comment on the MRI scans. So if we had any doubt that the patient is at risk, if you look at this MRI scan, you'll never have any more doubt that the patient is at serious risk. You'll see that even the muscles, even in T2, they're kind of becoming hyper intense. That does indicate a lot of activity going on in the muscles. And if you look at the central axial cut, you can see that the muscles are so thick, they're literally pushing onto the optic nerve. And the right-hand most coronal cut, if you look, you'll see that the inferior rectus and medial rectus are so thickened that they're almost abutting on the optic nerve. So all these things, even before you see a patient, if this scan comes to your hand, you know, all your antennas should be up that, oh dear, this patient seems to be going a bad way. Go on, please, Dr. Rajesh.
Impression being Graves' disease with active sight-threatening orbitopathy. Patient was given continued on anti-thyroid medications. He was also given IV methylprednisolone, injection methylprednisolone 500 milligrams over 3 days, and he was given radiotherapy at 20 gray was given over the course of 10 cycles with 2 gray between with each thing. Over the course of 2 weeks, it was given, and he was also given mycophenolate mofetil amounting to 1 gram per day supplementation.
So Rajesh, actually, we have discussed the patient and the severity was also pretty high. So NDTPO, this TSH receptor inhibitor trap was done or not?
It was not done in the patients.
Okay, now that Dr. Sanjay has brought up TRAB, let's look at what the other possible, serious risk factors were. So was the patient a smoker?
He was not smoker, ma'am.
And I suppose from the your thyroid reports, you could pretty well say that he had not gone into hypothyroidism.
Yes, ma'am.
Right?
Yes, ma'am.
Okay. And he's obviously not received radioiodine.
No, ma'am.
Right. Another factor which doesn't figure very prominently in the Western textbooks is co-presentation with diabetes mellitus. Okay, it doesn't come up in the UGOGO report. It doesn't come up so often, but whatever the recent publications from India are, including mine, all of them show a very strong correlation of poor prognosis with diabetes mellitus.
Yeah,
So,
exactly.
I mean,
Yeah, ma'am. Yes, continue.
I mean, not elevated sugar after steroids. I mean, all patients, if you take into consideration, the ones who had diabetes did much worse than the ones who did not have diabetes.
So the risk factor for the severity of the this Graves disease, Graves ophthalmopathy particularly. So first is diabetes mellitus. Second one, NT2 level. If it is high, then also it can worsen in time. Then third one is patient is if it is smoker. Then fourth one, older age, and another one is if the male. So in these cases, severity it can be very severe.
And we see this guy's ticking so many boxes. He has diabetes, he's male, he's elderly. So
yeah. So other thing in the patient, actually, you described these things. So HbA1c level was not described, I think. HbA1c, glycated hemoglobin.
Yes, sir.
Was it done or not?
It was done, sir. The HbA1c during the time of presentation was 6.5, sir. Actually.
Okay. So during the course of disease, was it repeated again?
It increased to 9, sir. The latest report was HbA1c of 9, sir.
Okay, so this may be the cause of this severity. No?
Dr. Rajesh, is that all the treatment given or anything more was also done?
He was
How
given
was the response to the methylprednisolone? Did the vision improve?
Initially, during the first 12 weeks of methylprednisolone therapy, patient has improved clinically, ma'am, with the activity score of being 1/7.
No, I'm talking about now. Now that he has neuropathy, now that he has optic neuropathy.
He has still decreased vision, ma'am, right now. His vision has not completely improved.
If I might
second time
go ahead, Dr. Sanjay. I'll
Yeah.
complete after that.
Yeah. So again, then the clinical activity score was 7/7. So you have given methylprednisolone 500 milligram over 3 days. So
Yes.
was 500 milligram OD for 3 days, or is only 500 milligram over 3 days?
It was OD for 3 days, sir.
OD for 3 days. So again, why it is only OD for 3 days they have given? Any particular?
Patient was referred directly for radiotherapy, sir, actually, during the time of this presentation. So patient was admitted in radiotherapy department and he was due to be given radiotherapy. So he was given a course of methylprednisolone along with that radiotherapy was given.
Okay, one of the things that has come out very clearly in recent years that once we go into dysthyroid optic neuropathy, it has to be a higher dose. So, initially we used to give 1 gram in 3 consecutive days. Now that's kind of changed to 750 milligram twice a week. But also, if the patient doesn't respond significantly within the first couple of weeks, it is a question of decompression. Because, radiotherapy does work and it works beautifully, but it takes time to work. So when it's a vision threatening, a sight threatening thing, if at all possible, one should lean towards the surgical decompression. What would you say, Sanjay?
Yeah, was it planned? Surgical decompression was planned or not? Just radiotherapy? They have given the radiotherapy and started on this mycophenolate.
He was given radiotherapy and started on mycophenolates.
Okay. So at that time, what was vision of patient?
Sir?
Vision.
Uh,
Was there
vision-
impression on this optic nerve?
Vision was reduced, sir, at that time, patient when he was admitted during radiotherapy.
Okay.
Yeah, I think that at that time, except radiotherapy, all other treatment was given in the other eye hospital. And vision at that time was already gone to 24/60. So that is all that patient was able to tell me verbally. The whole record was not available to us. But radiotherapy was done at our center. Ophthalmologist referred. So once they had treated this much, once they had started mycophenolate, after that the patient was referred to us for radiotherapy. And at that time, I'm not sure. Patient did not tell me about any plan for surgery, but I think that it might have been discussed and the patient refused, or whatever the discussion happened at that point. I am not fully aware of that. But the prescription did not contain any plan for decompression.
Go on, Dr. Rajesh.
This was a picture of the patient before radiotherapy, and this is a picture of a patient after radiotherapy. Here in this picture, he was having a conjunctival redness, along with that more of a lid edema with more proptosis. In the right side picture, you can see there is little improvement in the conjunctival redness, and the edema has reduced compared to the previous radiotherapy.
Rajesh, can you explain this CS score 7 in this first picture?
With the conjunctival redness and lid edema, sir.
Okay.
We cannot tell about lid redness here in this thing, and there is a edema near the caruncle region also, sir. Redness in the caruncle region, and pain and motility of gaze evoked pain also could not be commented in this picture.
Anything else? This conjunctival edema is not there. Chemosis is not there. No? So score is not 7. It should be lesser than 7. No?
Another interesting concept that has come up in the last few years is the concept of different types of phenotype of thyroid eye disease. All right. So there is one phenotype, which is the classical thyroid eye disease that's described with all signs of inflammation. There is another phenotype where it's a very quiet eye, but with very severe proptosis. Right from the beginning, it will be like that. The third one is one that deceives most people, that there's very little obvious sign of inflammation, but internally, the optic nerve is compressed. So that is actually the weak point of going only by the clinical activity score. Because once we get to know of all these different phenotypes, clinical activity score cannot catch the risk factors, the risky situation in some of them. So it's possible that when apparently the clinical activity score had come down to 1/7, but the disease was still brewing inside. And so it's very easy to be deceived, that we think that, okay, the patient is out of danger. But the sight-threatening thing was happening anyway.
Yeah, absolutely. Once we see in the patient that proptosis is more, chemosis is more, but actually the disease inside the orbit may not be more. No, it can be lesser, because depending on the soft tissue, fat, and some surrounding, the muscle, the outer part of muscle cells is involved. Muscle cells are not involved. Only the in between the muscle cells, what is the fibrous tissue that is involved in the disease. So if these muscles like rectus muscles, if they are stretchable, they are in the space to stretch, at that time proptosis will be there, but the disease is not so severe at that time. But sometimes, and also again in the orbit, we have the particular some quite more space at that time. It can go out, so proptosis will be there, but the disease is not severe. But sometimes we know the rectus muscles are not stretchable, so they are not, proptosis will not be there. So inside the orbit, there will be more use pressure will be there. So at that time, the optic nerve compression will be more, and the disease severity, that is grading and severity will be more at that time. So we cannot say if the eye is looking like that, if patients looks like proptosis, huge proptosis there, so we cannot say the disease is more. But in some patients, when the proptosis is lesser, at that time also disease can be more severe. So this clinical activity score is just only is showing the acute inflammation. What is the inflammation is going on right now? It's not showing the exact severity of the disease. So the grading should also include it to know the severity of the disease.
Go on, Dr. Rajesh. What more? Okay, this is exactly what we were referring to. This is the current guidelines.
The 2021 UGOGO guidelines for medical management of Graves' orbitopathy. They have classified the severity of Graves' orbitopathy into mild Graves' orbitopathy, moderate to severe, and sight-threatening. In mild, they have only minor impact on daily life, and it is insufficient impact to justify immunomodulation or surgical treatment. They have a minor lid retraction of less than 2 millimeters, mild soft tissue involvement, exophthalmos, and less than 3 mm above or normal for race and gender. No or intermittent diplopia and corneal exposure responsive to lubricants. In case of moderate to severe Graves' orbitopathy, there will be no sight-threatening Graves' orbitopathy whose eye disease has sufficient impact on daily life to justify the risks of immunosuppression if there is active disease or surgical intervention if inactive. They will be having usually 2 or more of the following: lid retraction of more than equal to 2 millimeters, moderate or severe soft tissue involvement, exophthalmos of more than or equal to 3 millimeters above normal for race and gender, inconstant or constant diplopia. In case of severe sight-threatening, very severe Graves' orbitopathy, there will be corneal breakdown, general measures for the diseases: cessation of smoking, and to treat thyroid dysfunction with anti-thyroid medications, and avoid iatrogenic hypothyroidism. In case of mild Graves' orbitopathy, artificial tears, corneal protection during night, and selenium of 200 micrograms per day for 6 months. In case of moderate to severe and active Graves' orbitopathy, first line of treatment being 500 milligrams of intravenous methylprednisolone per week for 6 weeks, along with mycophenolate sodium amounting to 720 milligrams per day for 6 weeks, 720 grams per day for 6 weeks. If there is a response or partial response, taper over the steroids to 250 milligrams intravenous methylprednisolone per week for 6 weeks, followed by mycophenolate sodium for 18 weeks. And if there is a response, then stop therapy. If there is no response or deterioration, go for second line treatment. Or either we can go with higher dose of 750 milligrams intravenous methylprednisolone for 6 weeks. And if there is a response, taper to 500 milligrams of methylprednisolone per week for 6 weeks. And if there is a response, stop therapy. If there is no response, proceed with second line of treatment. Second line treatment include a second course of intravenous methylprednisolone or oral prednisone with cyclosporine or azathioprine, orbital radiotherapy with oral or intravenous glucocorticoids, teprotumumab, rituximab, and tocilizumab. In case of sight-threatening Graves' orbitopathy, intravenous methylprednisolone 500 milligrams to 1 gram as a single dose, repeated on 3 consecutive days or alternate days, and daily monitoring of ophthalmic parameters. And after 1 week, if the therapy can be continued, further intravenous methylprednisolone for as in 1 week, and if there is a response, taper to 500 milligrams of intravenous methylprednisolone. And if there is a partial response or no response to the initial methylprednisolone therapy, urgent orbital decompression surgery. In case of inactive Graves' orbitopathy, rehabilitative surgery as required for the patient.
Thank you, Dr. Rajesh. That was indeed a very challenging patient. And you know that this patient, the difficulties that you and your team faced, that you couldn't get sufficient ophthalmic information from the patient because that data was elsewhere. That kind of underlines the need for working very closely between the, orbital disease person and endocrinologists. That your task probably would have been easier if you had had more direct feedback from the ophthalmology colleagues. Am I right? Would you say so, Dr. Alok?
Yeah, madam, I think you are right. The problem was, number one, he was for ophthalmology. He was going to a big specialized center in another hospital. We did not have any direct contact. And the only thing we could get was a prescription which had the advice for the current medication. That's all that we could get information out of that place. So that was that kind of problem was there. We did not get all the information. But still, I was still comfortable with it because he was following with another center. And at least I knew that he was getting good care, whatever was possible with that setup. And the other center also was probably reasonably comfortable with the endocrine care that we could provide. So even though it was not possible, means academically it is not very fulfilling, and professionally it is not very fulfilling that I did not have all the information, and our center did not have all the information, our residents did not have all the information that we really needed. But at least for patient care side, I think that it was not so bad. So even though I would have preferred something more, but this was also, I think it was better.
Absolutely, sir. And so I think we go on attempting to work more closely together. I think that should be the goal for all of us. And on this basis, I would really like to thank the team led by Dr. Pramila and Dr. Ganvi and their team. I've been involved in the treatment of a pretty large number of their thyroid eye disease patients. And, the coordination and cooperation has been lovely. I've really enjoyed working with them. As I must express my gratitude for being with you here today.
Excuse me, I'm Dr. Prasanna Kumar. There are 9 questions.
Namaskar, sir.
Namaskar. There are, to be fair to the audience, there are 9 questions or comments. Before we conclude, I think the moderator and all should answer that. And somebody can read those questions because the audience also come to ask their questions and it should be answered. I think
Yes,
Rapporteur can read the question for the
comment. I will read the questions. So
sir, I was just
is,
waiting if any of the panelists have any question before we go to the audience question.
Yeah.
I was just waiting if Dr. Prasanna Kumar, if you have anything, if you can ask, if you take the lead, then I will ask all the panelists and then we'll go to the audience question.
I don't have any questions, but there are very good questions and comments. I think you should go through that.
We'll take it. Okay.
Shall I read the question? The first question was CT orbits done before therapy and was IgG4 levels done? So that is one question. And this is the first part of it. Then we'll go to the other.
CT orbits was done before the therapy. Yes. IgG4 levels were not done in this patient.
Not done, yeah. Then the clinical activity score, if it is 4, then the question for Dr. Roshmi is, do we need to do MRI in all cases? If the patient cannot afford the MRI, then on what basis we can start the therapy? That's the next question.
Okay, based on clinical activity score, we can definitely start therapy. The indication for doing MRI would be, A, if there's a doubt about the diagnosis, particularly if it is very asymmetric. B, if we are suspecting dysthyroid optic neuropathy, the vision is down. So then the MRI is actually going to show us the muscles pressing on the nerve and see, if you're planning for surgical intervention for some other reason, maybe even for rehabilitation, then we need an orbital imaging. Just to start off on therapy, we don't need an MRI.
Absolutely, yeah. So then your experience with rituximab, a continuation of that, because we have used it for a few patients. So the one question from the audience is your experience with rituximab about, like, because there was a paper in JCM they're telling. So what's your experience with rituximab?
Rituximab doesn't work so well in a very acute phase. Rituximab is excellent when you have a kind of relapsing disease. It keeps on, the activity keeps on increasing. For that, rituximab is good. And what I've understood is a lot of the rheumatologists and whoever are giving the rituximab, they get very worried about the prolonged immunosuppression that it causes. Would you agree, Dr. Pramila, with that?
Yeah, because they are always worried about that. Yes, but we used it for, like, you only saw one of my patients where we had used, who had a relapsing disease, who didn't respond to steroids, and he had almost sight-threatening ophthalmopathy. So one more question for the team is that why was methylprednisolone, radiotherapy, and mycophenolate mofetil all given at the same time? Was it given at the same time, or was it stepwise? That's what basically the person wants.
It was given as stepwise, ma'am. Initially, it was given steroids along with mycophenolate mofetil. Later, he was referred for radiotherapy, ma'am.
Right. So a continuation of that only, like, if somebody cannot afford IV steroids, so can we give oral? That's the question. So
you want to take that?
Yeah, again, we have the robust data only with the steroids. For the oral steroid, we have the many studies are there, like prednisolone, that can be given with some equivalent results there, or otherwise in somewhere study has done that even dexamethasone has also been used for this Graves' orbitopathy. So IV steroids works better than this oral steroids, but now growing evidence are showing that even oral steroids can be given.
one more question is, please.
Sorry.
Yeah, please.
I think there was one study from PGI MER from Kolkata, and where Dr. Sujay Ghosh and his team had tried to compare oral prednisolone along with head-to-head with IV methylprednisolone. And the result was that the IV methylprednisolone was shown to be better. I don't remember exactly, but the response was probably 30 or 40% better than what was the oral prednisolone. And the probable reason why we don't get that good response with oral prednisolone is because we are not able to give that kind of high dose which IV methylprednisolone gives, and with a once-a-week regimen. Our oral regimen is not like that. Our oral regimen is a very small dose compared to what we give IV.
Yeah, true. So another question is, they are asking one, what is the pathophysiology of smoking aggravating the Graves' ophthalmopathy? Dr. Alok, would you like to take, or Dr. Saran?
I think that the pathophysiology basically is with the oxidative stress-induced damage and the inflammation that starts with it. But I won't know any further details. Dr. Roshmi, can you please help?
It is basically, if I can just add, it is basically more of tissue hypoxia, and there is more of pro-inflammatory cytokines which are released, and also there is some accentuation of the fibroblast expression. That is, these are the mechanisms. Dr. Roshmi can add on that. So these are the probable mechanisms which are there for cigarette smoking with Graves' ophthalmopathy. Dr. Rashmi, you can please add.
I think my contribution would be similar to yours. The only other extra thing that I know of, or I would say even you would be knowing, is that even secondhand smoke causes similar problems.
Yes, so even the passive smoking also causes a similar, because there is increased inflammatory cytokines and more fibroblast HLA expression, which is seen in smokers with Graves' ophthalmopathy. That is what the studies have shown. So we'll go to one more question. There is a case, sort of one doctor has put. So it's a 50 years old lady who was diagnosed with Graves and ophthalmopathy, received IV steroids with mycophenolate. Now MMF was discontinued after 3 months. The patient has again worsening of the ophthalmopathy. So planned for steroids, 4.5 grams dose they are planning again. So, and they are asking, can we restart the mycophenolate? That's the question.
Well, mycophenolate is recommended actually for 24 weeks. So 6 months. And in this case, it's given for 3 months. So possibly if all other body parameters are okay, it should be okay to give it.
So another question is, can cyclosporin be used as a second line rather than mycophenolate?
Cyclosporin is in fact one of the second line medications that are listed.
Yeah.
But the evidence right now is far more robust in favor of mycophenolate.
Yeah, so other questions are overlap, like oral or IV. We have already answered those questions. And one last question is whether we should do CT or MRI orbit in Graves ophthalmopathy. So Dr. Saran, if you want, you can take that question.
Yeah, depending, actually CT describe the bony architecture better than the MRI. MRI describe the soft tissue swelling or like that. So depending on the patient to patient, actually, if we want to get the muscle, the anatomy of the muscle, at that time we should go for the MRI. Otherwise, CT is sufficient. CT is sufficiently showing them all the muscles and the bony tissue and fat inside the orbital cavity. But actually these things only we do when diagnosis is in query or in severe cases. We do the ones that in case of sight-threatening cases. Otherwise, we need not to do these imaging studies.
Yeah. Dr. Rashmi, would you like to add something?
If we are planning decompression, particularly for rehabilitation, that is where CT scan holds the upper hand, because that shows us how much bone exactly there is. And so therefore, by drilling away the bone, exactly how much space I can extra create in the orbit. So that's where CT scan is a benefit. And if we are in doubt whether there is active disease or not, the hyperintense appearance of the muscles in the MRI will give us a better information of that. Other than that, as Dr. Sanjay said, the muscles and the optic nerve, the proximity, they're seen equally in CT scan and MRI.
So I think we have answered most of the questions. So Dr. Alok can continue further. Yeah.
May I ask a question?
Yeah, please, ma'am, please.
Yes. So for patients who have residual proptosis, when do you plan surgery and the types of surgery, Dr. Roshmi?
So we would be planning surgery when we know at least 3 to 6 months of inactive disease. So not only is there no clinical activity score, there's also no change in the measurements of the orbit. No change in palpebral fissure, no change in proptosis, no change in ocular movement. So if we are letting the natural course of the disease, because if we look at Rundle's curve, you know, the clinical activity as it comes down, even the severity comes down to a certain extent in a lot of patients. I would personally like to give the patient ample time to settle down as much as they can. Then it comes the question of what kind of surgery. It will always be the decompression first. What we know is by doing fat alone decompression, we can get 2 to 3 millimeters of correction. And if we want more than that, if we want 4 or 5 millimeters of correction, we have to add on bony decompression. And preferably, we should be doing a balanced decompression. That means both the medial wall and the lateral wall of the orbit, just because that reduces the chance of the patient later developing more diplopia, or it reduces the chance of worse strabismus happening. That would be talking about it very briefly. Ma'am, is that the question you meant, or
Yes, absolutely.
should I expand on anything else?
Thank you. I think we can move on now,
Yeah.
please.
Yes, ma'am. Yeah.
Thank you.
Quiz, we can, yeah.
Yes, ma'am. Thank you, Dr. Sanjay Shran sir, Dr. Roshmi Gupta ma'am, and Dr. Rajesh Reddy sir. Thank you, Prasanna Kumar sir, Pramila ma'am, and Sarita ma'am for a very captivating discussion. Now moving on to the most awaited session, that is the quiz. Now I request Dr. Alok Sachan sir to introduce the quiz master for today, Dr. Rajiv Singhal sir.
So, thank you, Dr. Ganvi, for guiding us to the next and probably the most interesting part today. So I have the pleasure of introducing Dr. Rajiv Singla. Dr. Rajiv is MD, DNB, DM, and FRCP from Edinburgh. He is a consultant endocrinologist at Kalpuraks Healthcare, Dwarka. Dr. Rajiv has more than 60 index publications, and citations are also quite a lot, 1,000 plus. He has Best Brief Communication Award in 2014, Best Review Paper in 2015, Best Original Article in 2019 from Indian Journal of Endocrinology and Metabolism. His interest areas are type 1 diabetes, technology amalgamation in diabetes care, and diabetes reversal. So over to you, Dr. Rajiv.
Thank you, sir. So, yeah, should I share my slides?
So first we will go through the quiz participation rules.
Yeah, sure.
Yes, sir. I request the IT team to display the quiz participation rules. Yes. So to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There'll be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or the description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at the end of 10 minutes. So to read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. Can we have the dummy questions, please? IT team, can you display the dummy questions? So the first dummy question, in which city is Taj Mahal located? Option A, Chennai, option B, Mumbai, option C, Agra, and option D, Bangalore. Going on to the second dummy question, how many oceans are there? Option A, 8, option B, 5, option C, 6, and option D, 7. So I hope all the participants could log in their answers. So over to you, sir, to start your session and start the quiz.
So, Dr. Ganvi, would the same format file would be shared in the same format by IT team?
Yes, sir.
Yeah,
Yes.
I think the questions are already there. So I think
Yes.
on everybody's screen. So I just don't need to share my slides. Do I need to share my slides?
Yes, sir. Yes, sir.
Okay. Okay, so these are, I think what I've tried to do is, these are very, very simple questions that I've shared. So basically all of them are very, very common things that we use in our practice. Only few of the things which come out from research or little higher. So question number 1 is, thyroxine should be stored at temperature. Less than 45 degrees is enough, less than 38 degrees Celsius is enough, less than 25 degrees Celsius is enough, or it really doesn't matter as long as the tablet is stored at a dry place. So the second question is, true about thyroid and PCOS are all except TSH increases adipocyte proliferation by acting on TSH receptor present on adipocytes. Leptin induces thyroid autoimmunity and also increases TRH levels. Insulin resistance and pro-inflammatory cytokines increases deiodinase activity at pituitary level. Metformin decreases TSH in PCOS patients. Okay, going forward to question 3. Modalities to differentiate between hyperthyroidism and early stage thyroiditis include all except radionuclide scan, anti-TSH receptor antibody, superior thyroid artery velocity, and thyroglobulin levels. So it's an except question. So 3 are used and 1 is not used. So you have to answer which one of them is not used. All are associated with increased risk of thyroid autoimmunity except high intake of iodine, hepatitis C virus, smoking, female sex. So again, an except question. So all are associated with increased risk of thyroid autoimmunity except high intake of iodine, hepatitis C, smoking, female sex. Question 5 is teprotumumab is a monoclonal antibody against IGF-1 receptor, TSH receptor, actin, fibroblast growth factor. So I think in the case just before this, we just heard about use of teprotumumab. So you just have to tell me as to this is a monoclonal antibody against which of these molecules. Question 6 is all of the following medicines should not be taken within 4 hours of thyroxine tablet intake in clinical practice. Orlistat, ferrous sulfate, erythromycin, calcium carbonate. Again, this is an except question. So 3 drugs cannot be taken, but 1 drug can be taken within 4 hours of thyroxine tablets. So you have to tell me which tablet is safe to be taken within 4 hours of thyroxine tablet. Tablet thyroxine can be taken 3 hours after last food intake, 6 hours after last food intake, 8 hours after last food intake, or 12 hours after last food intake. So we know that there is certain gap that need to be maintained. We take the tablet and then after, but how much gap do we minimally require before the tablet? That's the question. Which of the following TFT pattern can be explained by oral intake of biotin? So now we use biotin. A lot of people use biotin for skin and hair. A lot of multivitamins these have. We believe that this impacts measurement of thyroid hormones in the laboratory. So which of these can be explained by oral intake of biotin? Raised TSH and FT4, low TSH and low FT4, raised TSH and low FT4, low TSH and raised FT4. So which of them would suggest clinically that person might be using biotin? True about T4 absorption test are all except. It is done in refractory hypothyroid cases. It helps in distinguishing between defects in T4 absorption and T3 absorption. It helps in assessing patient compliance. Normal absorption is considered to be 60% by 4 hours. Okay, so the last question is replacement dose of thyroxine in microgram per kg per day would be highest in a case of 1-year-old with congenital hypothyroidism, 8 years old with autoimmune thyroiditis, 25 years old past old who has hypothyroidism post viral thyroiditis, and perhaps those would be same in all of them on per kg per day basis. So these were the 10 questions. Best of luck, please answer, and we would discuss it after some time.
So thank you, sir. So the answers will be discussed by sir at the end of the monologue, and the winners will be announced later. So moving on now for the next session, that is the session on approach to thyroiditis. I request Alok Sachan sir to introduce Dr. Pramila Kalra madam, who is the esteemed speaker for the next session. Over to you, sir.
Thank you, Dr. Ganvi. It is a pleasure to introduce Dr. Pramila. So Dr. Pramila has done her MD Medicine and DM Endocrinology from SGPGI. She is at present a professor and head of the Department of Endocrinology at Ramaiah Medical College and Hospitals. She also has FACE, MAMS and FRCP Edinburgh, other degrees. Her area of interest is thyroid disorders and gender dysphoria. She has 68 scientific publications in national and international journals and 23 chapters in various books. She has had multiple presentations in national and international conferences. Over to you, Dr. Pramila.
Thanks, Dr. Alok. So I'll just be talking about approach to thyroiditis. Now, because this is quite a big topic, so it will be very difficult to cover everything. So what I have done is I'll be talking a little bit about the important aspects of thyroiditis. So this will be my flow of presentation. I'll be just giving a brief overview in the next 10 to 15 minutes. Then I'll be just talking about a little bit about acute thyroiditis and then a little bit detail about subacute. And we have no talk is complete without talking about COVID-19, where thyroiditis is commonly seen. And we all are seeing cases of thyroiditis with COVID-19 and 2-3 slides on postpartum thyroiditis. So basically, when we say the word thyroiditis, a lot of patients do come to our OPD and they show us a report of the ultrasound, or they say that this is a thyroiditis. I have developed thyroiditis. Now, thyroiditis basically just reflects an inflammation of the gland. Now, it can have varied reasons for the cause. So it can be autoimmune, it can be infectious, it can be drug-induced, it can be because of varied reasons. And why it is important? Because these patients can have transient thyrotoxicosis. They may develop hypothyroidism over a period of time, and they may continue to be permanent hypo also over a period of time. So when we classify thyroiditis, we know that the infectious thyroiditis, this is very rare, fortunately, because the thyroid has a very good hormone, the blood supply, and it has a capsule. It is much away from the other organs. So we know that this infection is very, very unlikely in adults unless they are immunocompromised, or in children where there are sinus formation and which can be having a recurrent infection. Then the commonest thing which we see usually in our OPD is subacute thyroiditis, where the patients come with the thyroiditis or thyrotoxicosis post-viral infection. They may have pain, they may not have pain, which we commonly call as the subacute thyroiditis or the granulomatous thyroiditis. Then we have the autoimmune, even Hashimoto's thyroiditis, lymphocytic, postpartum thyroiditis. These are all coming under the category of autoimmune. Then we also can have thyroiditis associated with other thyroid disorders. Like if suppose a patient has a papillary CA, they may still have focal thyroiditis, and now it's a well-known entity. We know that thyroiditis or areas of fibrosis can be there in the areas of CA, can be there in between. So this is also one of the things which we need to know. And then there is an entity called as radiation thyroiditis. And then we know we have drug-induced sarcoidosis associated with thyroiditis or amyloidosis. Just for the drugs detail, we know that a lot of drugs can cause thyroiditis, but we need to know few of the things. Like we know that amiodarone, which is commonly associated with thyroiditis, where there can be two types. We may have a type 1, where there may be a thyrotoxicosis, which is because of the increased synthesis of the thyroid hormone. And this is usually seen in patients with pre-existing goiter. And then we have the type 2, which is more like a destructive thyroiditis. And then we mostly see a combination of both. And then we have many drugs, other drugs like interleukin-2, interferons, or kinase inhibitors, or even lithium, which can present with thyroiditis. So the patients normally present sometimes with pain, sometimes without pain. So it's not necessary that all patients with thyroiditis will have neck pain. They may just present with some symptoms of thyrotoxicosis. They may present with a report, or they may have some thyroid pain. So if the patient has pain and has some toxic appearance, and the patient has a history of an infection also, this clearly shows that there could be one infectious thyroiditis or some subacute thyroiditis, which could be one of the things. But when the patient has pain and they have toxic appearance, but they don't have any history of trauma or radiation, and they have low TSH, they have high T4, and they may have some preceding history of viral infection, we can think of subacute thyroiditis. Very rarely, as I said, infections because of bacteria or fungal is very rare. Even tuberculosis sometimes is seen, but this is rare. But especially in immunocompromised patients, you can see, and even there are studies or cases to show that even post-FNAC patients may sometimes develop bacterial thyroiditis if the hygiene or the needle is not correctly sterilized or it's not taken care of. Then very important to understand that we also can have postpartum thyroiditis, where the women after delivery can present with thyroiditis, which we'll be discussing a little bit. And we have another entity which is called as the Hashimoto's thyroiditis, where the patient may, over a period of time, go on to the hypothyroid phase as well. So acute thyroiditis, it can happen in any gland, in a normal gland, but there are some predisposing factors, especially the immunocompromised state or of sinus, which can make the patient's gland susceptible to infection. The common organisms, which are bacteria, which are seen are like staph, streptococcal, and E. coli, and we can have anaerobic organisms as well. There can be some atypical mycobacteria, which can also cause suppurative thyroiditis, especially, and some fungal infections and parasitic infections as well. But again, to add, these are very rare, but we do see cases of this. So this is commonly seen in pediatric age group, where the patients may have a sinus fistula and they may develop recurrent attacks of acute thyroiditis. They may have lymphadenopathy, they may have fever, pyrexia, and we know that the infection can progress if not taken care of, and they may have severe pain, and they may also come with possibility of going into septicemia if not taken care of. But also we have to understand that these type of patients, when they come to us, sometimes in adults, there may be a vague painful mass in the thyroid region without fever, and sometimes anaplastic carcinoma can also present like that. So it's in the adulthood, we should always think of the other possibilities as well. So as expected, if there is any infection which is bacterial or fungal and not taken care of, it can cause more problems if not taken care of on time. And these patients may have high blood counts, and they may mostly be euthyroid, but they may have some transient elevation of T4, which is reported in some of the studies. And we know that if we do a technetium 99 scan or a radioactive iodine uptake, the uptake may be low if the inflammation is diffuse. The diagnosis is made by doing an aspiration to see what exactly it is, and accordingly the patient has to be treated. Now coming to the subacute thyroiditis. Now this is something which we commonly see, especially in areas like Bangalore. We commonly see these patients almost throughout the year. And this is also called as granulomatous thyroiditis, and it is an inflammatory disease. There are some associations with HLA which have been seen and have been studied in some population. Also, the patients who have these HLA association may have a higher recurrence of subacute thyroiditis as well. Many a times we do get a history of viral infection, but it's not necessary. Sometimes the patients may give a history, or sometimes this could be the only manifestation. So we know that there are different viruses which have been implicated, starting from the Coxsackie to adenoviruses, to influenza, to mumps, and HIV also. But COVID-19 is one of the latest, which we know could be one of the etiologies of this. And we have seen many patients, and I know that all of you would have seen, where the patient may only manifest as thyroiditis and not any other manifestation of COVID. And in the case series of COVID-19 and thyroiditis, which has been published, it has been seen that the patient may have a very mild COVID, but they may have severe thyroiditis. Or sometimes, many times it was seen that these patients may have subacute thyroiditis, but they may not have pain, and they may just manifest with thyrotoxicosis. So these are the varied manifestations which have been reported. So we have to also understand that it can be painless sometimes, and children can also be affected. There are case reports of even very young kids of 4 or 5 years getting affected and manifesting the symptoms. So we know that subacute thyroiditis initially obviously presents with a high T4 level, and over a period of time it drops, and then slowly it comes back to normal. So sometimes what happens, the patient comes to us in this scenario, and erroneously sometimes it is thought of that they could be secondary hypothyroid, and they may continue to have a low T4 for some time. The TSH most of the times come to normal in around 2 to 3 months. But again, to add here, sometimes it may have a longer course. And also what happens that these patients sometimes may have transient hypothyroidism, which mostly recovers, but some of them may continue to have permanent hypothyroidism over a period of time. But the maximum number of patients revert to euthyroidism over a period of 3.5 to 4 months. So they may come with a swelling, they may come with some other severe symptoms. Sometimes there are patients who may even come with vocal cord paresis. They may have sometimes very severe pain, fever, they may manifest as pyrexia of unknown origin as well. So sometimes we do see patients were investigated for a long time and the thyroid functions were not checked. And when we see the thyroid functions, they actually have thyrotoxicosis, which is secondary to thyroiditis. So when we palpate, there may be tenderness over the thyroid, but that's again not 100%, not all patients may have it. This was one of our data where we tried to see the thyroiditis prevalence in our city. So we did this study over a period of a year, and what we found that Bangalore climate is like that. So we do have viral infections and respiratory infections all throughout the year. And we did see an increase during the months of June, July, August, and then there was a little bit of a drop, but all over the year, we did see lots of patients. And obviously the predominance population which was affected was females, and males were much less. And this is what is known from the other studies as well. So when we talk about thyroiditis, we know that these patients may have a history of prior upper respiratory tract infection, may have fever, may have toxicosis, may not have, may have sore throat, may have some other associated features. And when we do the technetium-99 scan or the iodine, normally we do the TC99 scan, we see that the uptake is almost negligible, or there is no uptake at all, except in the recovery phase where there may be sometimes an increased uptake, which is seen. Some of the studies have been done where people have tried to see other surrogate markers, which are still not in the guidelines, or we cannot say that this is what we do and I get this value and make a diagnosis. But people have tried to correlate it with the platelet lymphocyte ratio, monocyte eosinophil ratio, free T3 to free T4 ratio, or the neutrophil lymphocyte ratio. But these are all the surrogate markers which have been studied in different studies. So as I told you, patient may have neck pain, they may have a history of respiratory tract infection, and they may just present to you with fever. They may present to you with a thyroid function report where the TSH is suppressed, the T4, T3 may be a bit elevated, may not be too much elevated, sometimes they may be. And these patients mostly are antibody negative. And when we do the technetium-99 scan, we see that there is hardly any uptake. So as I was talking about the hypothyroidism on follow-up in a cohort of patients, so what we saw in our data that the prevalence of hypothyroidism in these patients of subacute thyroiditis, which was existing or persisting at 1 year, was around 19.86%. So this is what we saw in our data when we did the study in our center. Also, one very important thing is subacute thyroiditis may be associated with some malignancy. So as I told you, even an anaplastic thyroid cancer can sometimes present like a typical neck pain, and they may have some fever also because of the necrosis of tumor. So they may erroneously be labeled as subacute thyroiditis. So we have to be a little bit careful when we have a little bit of a diagnostic dilemma and we are not very convinced with the diagnosis of thyroiditis. And sometimes differentiated thyroid cancers can present with thyroiditis as well. So patient may have papillary cancer and they may present like thyroiditis. The treatment modality is very simple. It is symptomatic. We have to give anti-inflammatory analgesics. There is some role of zinc which has been seen. We also give them like beta blockers if the symptoms of toxicosis are severe, but we have to also see that if the patient is not responding, if the symptoms are more severe, pain is severe, and the patient is not responding to this normal treatment, then we might have to give steroids to some of these patients, which might need to be given for a period of 6 to 8 weeks. And the dosage is tapered slowly, about 5 mg per week, which can be done for the patients only in whom the anti-inflammatory, the NSAIDs are not showing the effect and the disease is quite severe. There are many studies with steroids and NSAIDs, but this was one of the interesting data which they found that the patients who were given steroids, the recurrence rate, they found that it was more in patients who received only steroid therapy as compared to patients who were treated with the NSAIDs alone. And also another interesting data which they found out that persistent hypothyroidism developed in around 22% of patients who were treated with the NSAIDs and 6.6% in patients treated with steroids. So steroids did protect against the development of hypothyroidism, but the recurrence rate was higher in patients, and especially there are other studies where they have shown that too fast a tapering of the steroids sometimes can cause more recurrence. So sometimes what happens, steroids on an average are given for 9 to 10 days, and those patients may have more of recurrence. Another drug which has been tried in few of the isolated cases was colchicine, where they have tried this also, where the patients have responded, but this is just one of the drugs which have been tried but not used mostly. So anti-thyroid drugs have no role. That we have to be very clear. There is no role of anti-thyroid drugs. If the patient develops hypothyroidism and it is very transient, TSH is below 10, normally we don't give any levothyroxine. But if it is severe hypothyroidism, we do give levothyroxine, may give levothyroxine for a short period. But we also have to understand that most of these patients will have a transient hypothyroidism and they'll recover. Recurrent thyroiditis is another entity. So this can occur in about 14% of cases. Again, it has been seen that it's just associated with HLA. As I told you, there are studies to show that if the steroid tapering is done too fast, it can be a factor. Not to forget COVID-19, because we know the ACE2 receptors where the COVID virus attacks, and we can have a painless thyroiditis, we can have a painful as well. And these patients may have the only manifestation of thyroiditis rather than the COVID itself. So most of the case series which have been published have shown only mild symptoms of COVID, except few where the patient had pneumonia as well. And some of them were actually asymptomatic. And we also have seen in our practice a lot of patients who have just come with asymptomatic COVID infection, though they are COVID positive, but they have just manifested with thyroiditis. Postpartum thyroiditis, just a little bit about it. We know that it can manifest with transient thyrotoxicosis. It can go into a transient hypothyroidism and recovery. This is a classical form, but sometimes the patients may have permanent hypothyroidism. And it's an autoimmune disease. Patients who have antibody positivity have a higher chance of getting it. And these patients can have permanent hypothyroidism. They may recover, but some of them land up with permanent hypothyroidism. And also these patients may present with just a painless thyrotoxicosis initially. Sometimes they may be just symptom-free and just diagnosed on routine investigations, or they may come with palpitations or fatigue. Most of these patients will just require symptomatic treatment, but if they develop hypothyroidism, they might require, but many of them do recover after the hypothyroidism phase. Management of thyrotoxicosis in postpartum, again, is just by the, for a short period, symptomatic may be required, but mostly these patients will recover. Low dose of beta blockers can be given if the patient is quite symptomatic. So what we have understood is most commonly we do see drug-induced thyroiditis, we see subacute thyroiditis, Hashimoto's thyroiditis, we are all aware. But after that, if we talk about, we see subacute thyroiditis and we do see drug-induced, which we all need to know. And we need to know that even a subacute thyroiditis patient may have painless enlargement. It's one of the modalities by which we differentiate and decide is TC99 scan, because we know that there's almost zero uptake or no uptake in thyroiditis as compared to Graves, where you'll see an increased uptake. Drug-induced is one of the important entities, especially with the new anti-cancer monoclonal antibodies in the market. We do see a lot of thyroiditis developing, and very important to understand that post these drugs, the thyroiditis which develops can happen after a few months also. It may not happen immediately. So that's another thing. The history is very important to ask if the patient has received any such thing. One thing which also we need to understand is malignancies can be associated. So sometimes it can be a mimicker. The patient might present with a picture of subacute thyroiditis, and we may just continue treating it as subacute, but they may be having or harboring a thyroid malignancy. Even there are cases to show where the metastases to the thyroid has manifested as subacute thyroiditis, and the patient actually had metastases. One of the case reports did show a lung metastases to the thyroid, and where the patient was erroneously diagnosed as subacute thyroiditis. So these are all the varied presentations, and not to forget the COVID virus and the COVID vaccine. So we do see a lot of thyroiditis after the mRNA vaccine also. There are studies. There are case series now where the patient who have received the COVID vaccine, they have developed thyroiditis ranging from a time period of 24 hours to a week to 10 days. So that is another thing which we need to keep in mind. So all these are the possible case scenarios and which we commonly see in our OPD setups. So I think with this I end.
Thank you, Madam, for a very explicit talk. I now request Dr. Rajiv sir to discuss the answer keys and then to announce the winners. So you're on mute.
Yes, sir. Thank you. So do we already have answers from our participants?
Yes, sir, the answers are there. They're still, I think, collating the results.
Great.
During that time, we can have the discussion of the answer keys. So.
Yeah, sure. Let me share my screen. Yeah, so this is the answer to our first question. So if you look at, so what I've done is I've just put up a picture taken right from the tablet that we use all the time. So it clearly says that store at a temperature not exceeding 25 degrees. So the right answer to the first question would be less than 25 degrees. There can be a variation if you would go and read the prescribing information. So they would say that maximally it can tolerate a temperature of 30 degrees, but less than 25 degrees is what the ideal temperature is for this tablet to be stored. Second answer would be, this was, I think, was the only question which was little not of a practical utility per se, but so we published a paper in 2015, Thyroid Disorders and PCOS, an emerging relationship. And I think this was the talk given to me by Dr. Kalra and Sarita Bajaj ma'am, because somebody withdrew at last moment. But then when we looked at it, it was a huge treasure trove of data. And we have more than 100 citation of this paper now, of this review paper, thanks to ma'am. So basically what this concept is that thyroid, obesity, PCOS, basically they are connected in a circle, and they each and everybody accentuates the other disease. So not only TSH increases adipocyte proliferation because the TSH receptor is there on the adipocytes, but also the leptin which is produced by the adipose tissue kind of induces thyroid autoimmunity, as well as it works at hypothalamus pituitary level and increases TRH levels. What insulin resistance and pro-inflammatory cytokines does is they decrease the deiodinase 2 activity, thus making less T3 which is available at pituitary level, and which gives rise to again increase in the TSH level. So the obesity, insulin resistance per se would also contribute to increase in TSH. And the upcoming concept also is that the metformin decreases TSH in PCOS patient, but metformin does not decrease TSH in people who do not have PCOS. And there are subsequently more original articles are coming up, and I've posted 2 more recent articles from Journal of Indian Thyroid Society, so which are there, which kind of also state the similar fact. So the answer in this question was the third. So it does not increase, it decreases the deiodinase 2 activity. So answer 3 was modalities to differentiate between hyperthyroidism and early stage thyroiditis include all except. So answer to that would be thyroglobulin level. So radionuclide scan and anti-TSH receptor antibody, all of us know that are used to differentiate between 2. There has been a lot of paper because radionuclide scan and TSH receptors antibodies are not available in tier 3 cities or villages, while ultrasound has been penetrated more deeply into rural India. So this modality is upcoming, and where they say that if we are able to measure velocities in superior thyroid artery, then we can differentiate between hyperthyroidism and early stage thyroiditis. The cutoff of velocities are still still being worked up in the studies, but anything which is more than 40 centimeter per second to 60 centimeter per second, kind of in 2 different studies, they would say are kind of can differentiate between early stage thyroiditis and hyperthyroidism. So answer in this case would be 4 thyroglobulin levels. Okay, so all are associated with increased risk of thyroid autoimmunity except. So I think the answer to this is smoking. So in this case, this is I was also surprised. I was looking for something else, to be very frank, and then I found this. So smoking in case of thyroid autoimmunity has a paradoxical effect. If you've got a thyroid eye disease, as we discussed earlier, it's one of the single most important factor which aggravates that. But in case of hypothyroidism and hyperthyroidism, which are not associated with eye disease, then smoking actually decreases the prevalence of autoimmunity. So a paper in clinical endocrinology by none other than Dr. Veer Singha. So it says current smoking lowers the risk of developing thyroid peroxidase and thyroglobulin antibodies and subclinical and overt autoimmune hypothyroidism. The effect is dose dependent and disappears within 3 years of quitting smoking. So the answer to this question was smoking. Answer 5, teprotumumab is a monoclonal antibody against. So teprotumumab is an upcoming treatment for thyroid eye disease. The results far outpass the results shown by IV glucocorticoids, and it is being seen as the future therapy, first line future therapy for thyroid eye disease, and it's an monoclonal antibody against IGF-1 receptor. So the answer would be 1, IGF-1 receptor in this case. All of the following medicines should not be taken within 4 hours of thyroxine intake except, so the answer to that is erythromycin. A lot of medications that we take, they interfere with absorption of thyroxine tablets from our stomach. The most commonly that we used, and which I've not actually written here, is antacids. So all kind of the pantoprazole, all antacids, they uniformly decrease absorption of thyroxine, and iron and calcium. So these are the 3 commonly used, and they are especially important in pregnancy, where we are trying to maintain those TSH levels very, very tightly. And these all these are being given during that time. So we need to take care that these tablets are not given within 4 hours. And similarly for orlistat also. So answer in this case was erythromycin. Tablet thyroxine can be taken. So this question arose because a lot of people who work during night time, and then they come back home in the early mornings, and then they sleep, and then they say it's very, very disruptive for us to kind of take this tablet after we get up. We just have to go out, and we really can't wait. Our morning is not the usual morning. So it can be taken 3 hours after last food intake. So people who kind of work in the night, we just tell them that, okay, if you keep gap between your last meal and the tablet thyroxine 3 hours or more, then it should be okay. These are the ATA guidelines that I have demonstrated on the right side. So the answer would be 3 hours after last food intake. Then which of the following TFT pattern can be explained by oral intake of biotin? So basically biotin is used in all the immunoassays that we nowadays use to measure TSH and T4 values, and it has shown greatly to kind of interfere with those values. So it does not impact thyroid or TSH or T4 levels per se in the blood, but it interferes with their measurement. So if somebody is on biotin, then the TSH would come out as a falsely low, and FT4 would come out as a falsely high levels. Thus, it would mimic something like hyperthyrotoxicosis report. So if patient is clinically euthyroid, there is no way that we are kind of believing that that patient can have report like this. Then we should go back and ask for the biotin if that person has been taking biotin. And now we routinely write in the prescriptions that if you've been taking biotin, please discontinue it for as a precaution. We say 3 days, but the general guidelines are that at least for kind of the newer assays, they say that at least 8 hours should have passed between biotin and the test. But again, we are not sure as to how much dose of biotin in some of those supplements are. So would be a good idea to keep a gap of couple of days before we do the thyroid test. So true about T4 absorption tests are all accept. So T4 absorption test basically is done in people in whom they have a resistant TSH. So we've been gradually increasing their dose, and then their TSH does not come down. So when we are expecting an absorption defect in them, so it is done specifically for T4. So it is not done for T3. So answer in this case would be helps in distinguishing between defects in T4 absorption and T3 absorption. So people clinically present as refractory hypothyroid cases, and we does clinically, it is useful in assessing patient compliance. I can give you a very, very interesting example for this. So there is this one lady who used to came with her husband, and her TSH always used to be 150, 200, 125. And then I kept on saying, you're not taking this tablet. And they would say, no, we're taking every day. We're taking every day. And then I said, okay, let's do this. We did this, came out that the tablet was being absorbed. We put her on a weekly supervised therapy. 6 weeks down the line, TSH was 4. And then when I asked the lady, then she said, I already have 4 children. The family is forcing me to get married. If my TSH is not controlled, then nobody is forcing me to have pregnancy again. So that's the story of India that we have. So TSH of 125 is acceptable, not having a communication channel with in-laws is more difficult problem for people to solve. And then there are algorithms which say, based upon T4 levels at baseline and afterwards, as to how much tablet has been absorbed. So 60% is considered to be absorbed after 4 hours. So that's considered to be an appropriate response. So the last question was, replacement dose of thyroxine would be highest in a case of. So in that case, answer would be 1-year-old with congenital hypothyroidism. These children required significantly higher dose in microgram per kg per day as compared to people who usually develop it post-thyroiditis or autoimmune thyroiditis. Thank you.
Thank you, sir. I now request the IT team to display the quiz winners. I request sir to announce the quiz winners.
All right, so I think quiz winners are already there. So Dr. Shruti R is the first winner. Dr. Bharti Kola is the second winner, and Dr. Sujna Togarla is the third winner. So congratulations, kudos.
Thank you, sir. So for the next session, we have, it's a slightly different session. That is the last session of the thyroid clinics. We have the thyroid ultrasound workshop, where we'll be having quiz in the beginning, followed by the workshop. So the workshop and the quiz will be conducted by Dr. Krishna G. Sheshadri sir and Dr. Gokula Krishnan sir. The session will be moderated by Dr. Neelaveni ma'am. Before we conclude, I would request everyone's participation for the next session. And I request Dr. Sarita Bajaj madam and Dr. Pramila Kalra madam to say a few words before we conclude.
Yeah, so I think we have come almost to the end of the session today. And we had a nice discussion on thyroid ophthalmopathy. And we got a lot of insights from the ophthalmologist, Dr. Roshmi, and Dr. Alok and Dr. Sanjay Saran contributed to it. And Dr. Reddy presented the case nicely. So we learned a lot of new things. All of us keep on learning, because endocrinology or any branch of medicine, we always learn from each other. And then we had an interesting session of the quiz, Dr. Rajiv. That was very interesting, because we had some basic questions, but difficult, because many times we don't look into those answers only. And when somebody asks, then we think, oh, is it the right answer? So that was quite interesting. So I think we had a nice discussion on all these topics. And then obviously I talked about subacute thyroiditis and thyroiditis. So it brings us to the end of the session today. I think Dr. Sarita Bajaj ma'am would like to give the concluding remarks, and then we can conclude.
Sorry, Dr. Pramila, just I think the last question which has popped up in the
I'll
question
just
and
answer.
answer is probably related
Yes,
to you.
yes. So I was just typing the answer actually. So the thing is that what I will say in this, that if we have a TRAP positivity, I think it is TRAP, they have written TRAN, I think it's a typing mistake. So it's a TRAP positivity she's trying to tell. So what I would say is, there are two scenarios in this. Early Graves can have a normal TC99 scan uptake. So if it's TRAP positive with normal uptake, it can still be early Graves. We have to see if there are any ophthalmopathy, any goiter, anything is there, and then accordingly decide. Other thing is, there are possibilities that TRAP can be rarely positive in subacute thyroiditis also. So that's very rare, but there are possibilities of that as well. But this type of case, what I would do is, I'll follow up the case in 6 weeks to 2 months. I'll see if the thyroid is normalizing. I'll also see the ESR, which will give me an indirect evidence. If the ESR is elevated, it will suggest more of an inflammatory disease. But with a TRAP positive with 1.9% uptake, I would follow up. If it's not normalizing in another 6 weeks to 2 months, and it's on the rising trend, then I would think that it could be an early Graves and will need treatment with antithyroid. That's how I would approach. I think Sarita Bajaj ma'am would like to give a concluding remark. Ma'am, Sarita Bajaj ma'am, I think ma'am is having some issues with her connectivity. I think ma'am has some issues with her connectivity, I think. So Ganvi, shall we end then?
Yes, ma'am.
Because,
Yes.
yeah. So I think with this, we end today's thyroid clinics. It's always an interesting session. We always discuss new things and learn new things. Now ma'am has come. So ma'am, we wanted your concluding remarks.
Thank you. So I think this was a very wonderful session. The case was very interesting and very well discussed by Dr. Alok and Sanjay. Thank you for that. And I think comments, the questions also were very nicely answered. I think Dr. Roshmi's contribution was enormous. And I think she highlighted a very valuable point that we need we need to work as a team when it comes to eye examination. I think, Pramila, you have had a lot of success in that regard regarding management of thyroid ophthalmopathy. I was just wondering, how often do you need to go in for surgery? Say out of 10 cases, do you think maybe 1 out of 10 or even less than that?
Even less than that. Many of them respond to medical, and we have options of medical therapy now. So I don't think so much of it, but yes, definitely if it's a sight threatening, those are the cases, or cosmetic, but that will be over a period of 6 months to 1 year. Once they are in total remission, then only we think about it. And many of the patients actually for cosmetic, once initially they opt for, but once we see them after 6 months to 1 year, they are mostly comfortable and most of them don't go for it. But sight threatening is something where we actually had patients and where Dr. Roshmi did the job, but it's not so frequent. It's quite less. Most of them respond to medical.
So thankfully, we do have all those medical options. We don't need to go in for surgery. Thank you, Rajiv. That was a wonderful quiz and well discussed as after the talk. Thank you, Pramila. And we were planning to have Nihal Thomas, but he had some urgent work, and it was very, very nice of you, Pramila. And the thyroiditis was one topic we had not covered. And I think you've highlighted all the aspects very well. And then we have, of course, our reporter, Gandhi. Thank you so much for being with us and taking us through the program. The quiz winners, congratulations to them. Thank you to Asmita and Priyanka, who are there from the digital team. Thank you. And Dr. Prasanna was also there. Thank you. He's our patron. So the next webinar, Ganvi.
Yes, ma'am. The flyer was put up. I request the IT team to put up the flyer again. So for the next session, we have that thyroid ultrasound workshop, in which first we'll be having the quiz, followed by the workshop by Dr. Krishna G. Sheshadri sir and Dr. Gokul Krishnan sir. And this will be followed by following the workshop, the answer keys will be discussed. And the session will be moderated by Dr. Neelaveni. So we request everyone's participation for the next session. So stay connected, stay safe. With that, we conclude today's session. Thank you, ma'am. Thank you, everyone.
That will be the last session of thyroid clinics for the year. And we are ending with the ultrasound, the workshop. Thank you. Thank you, everyone. Thank you, Alok.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am. Good night.